sir, we all are aware of the IHR registry, in which most of the patients, around 50% of the patients, were having valvular atrial fibrillation. So in relation to that, we have come across that some new data is coming up where the main focus is on the non-valvular atrial fibrillation. So can you just elaborate on this kind of new data which will be coming up recent?
Yes. Dr. Sahu, thank you very much for inviting me. This is a global GARFIELD's non-valvular atrial fibrillation registry, which was done by Thrombosis Research Institute at London, TRI, under the leadership of Lord Ajay Kakkar. And this was done in 35 countries, and we were the partner to that. I was the national coordinator for this trial, this registry. And we have the largest registry so far. We have recruited 57,262 patients in this registry, out of which our contribution was 1,387 patients. As you rightly said, the IHS registries, which was more than 1,500 patients, included around 48% patients with valvular heart disease. So we do not have any clean data of our country on non-valvular atrial fibrillation, how we are managing and what is the follow-up. So this registry, which concluded in 2016, we participated in that, and in that we found, when we compared the baseline characteristic of our country versus the rest of the world, we found there were key differences. One of the major differences we found was the age. We are getting non-valvular atrial fibrillation in approximately at the age of approximately 65 years versus 69 years rest of the world. We found we have more diabetes, we had more coronary artery disease, but we had less number of patients with hypertension, hypercholesterolemia in our population. This was one important thing. Now these patients, they were followed up for 1 year also. Now once we look at the baseline characteristic, we looked at the pattern of treatment of these patients, those who were recruited in this registry. And what we found, there was a distinct difference between our country and the rest of the world. Roughly 20% of the patients were not on any drug versus 10% in the rest of the world. If you look at the anticoagulant uses, were approximately 35% in our country versus 68 to 70% in the rest of the world. If you look at the dual antiplatelet agent or single antiplatelet agent uses, was very high in our country, 45%, which was almost half of that in the rest of the world. So the treatment pattern which we found was distinctly, we were under-treating our patients, because these are the patients, those who had non-valvular atrial fibrillation with one of the risk factors, those who needed treatment for the other anticoagulation and follow. Now, when we looked into the CHAD-VAS score of these patients and HES-BLED score of the patient compared with the rest of the world, what we found, the Indian patients' CHAD-VAS score and HES-BLED score was almost similar between us and the rest of the world. And when we look at the treatment, as I told you, we were under-treating our patients. Now, if you look at the follow-up of this patient at end of 1 year, what we found was that there was increased mortality which was observed in our population, but surprisingly there was less of stroke and less of bleeding events in this patient, those who are there. But at the same time, when we look into this subgroup analysis of patients, those who are on vitamin K antagonist in this population, here we found that when we compare patients, those who are vitamin K antagonists between India and rest of the world, our population having INR between 2 to 3, which is desirable INR, was seen only in 25% of patients versus 50% patient rest of the world. If you look at the time in therapeutic range, what we say TTR, was 26% in our country, it is a 55% in rest of the world. So what we found, that we are underdosing our patient also. So in conclusion, what I can say, that in GARFIELD registry, where we took patient of non-valvular atrial fibrillation with one of the risk factors, we found our population is younger, we are having more coronary artery disease, we have less hypertensive, we are having less cholesterol, and although the treatment wise, the novel anticoagulants, NOACs uses were only 5 to 6% in our country compared to 20% in rest of the world. And the unfortunate thing what we found was that most of our patients are undertreated and they are also dosed. Their doses was also not adequate. That's why we found the result that the INR was very low. Although the stroke and the bleeding risk were little less in our population, this can be explained on the basis of younger population. Probably we were less hypertensive, but we had increased mortality, probably because one of the factor may be that we are having patients with more coronary artery disease, and also probably we are not treating them adequately. So comorbidity treatment probably is lacking in our country, which has resulted in increased mortality in this one. So it's a very, very important message which has come from the GARFIELD subgroup analysis from India, the non-valvular population, that we have to improve the management strategies of atrial fibrillation in our country. Because in this study, majority of the patients were recruited from the secondary and tertiary care hospital in the country from 21 centers. So that shows that in those centers, even we are under-treating or underdosing the patient. So there's a great room to improve the management of atrial fibrillation in the community.
Right, sir. So, sir, based on these findings of Indian sub-analysis part of this, one of the largest GARFIELD non-valvular atrial fibrillation registry, do you think that this will definitely change the current practice of the cardiologists?
I think so. If we give this message to our fellow physicians, probably they will be getting more confident. As such, we have seen that this registry was basically on 5 cohorts, which was done from 2010 to 2016. 2016 the study finished, and now we are follow-up phase. Now in this last 5 to 6 years, world over we have found there is increased uses of anticoagulants, but more uses of NOACs versus vitamin K antagonist. In our country also we found same finding, that the uses of anticoagulant have definitely increased. From 2011 to 2016 there was an increase. The uses of NOACs is also increased, use of vitamin K antagonist is used, but still a lot of patients are on the antiplatelet drugs, which is not justified, because we know now that the antiplatelet drug has got no role in patients with non-valvular atrial fibrillation, those who need treatment, those who have got high CHA2DS score. So if we send this message, probably we need to increase the uses of these drugs, which will result in reduction in cardiovascular events and mortality.
Right, sir. So, sir, what will be your final message to all the cardiologists who are managing the patients of non-valvular atrial fibrillation?
You see, they should now get the confidence to use the anticoagulants in patients of non-valvular atrial fibrillation. And the only problem in our country at the moment is that the NOACs which are there, like dabigatran, apixaban or rivaroxaban, all the 3 drugs are costly in our country compared to warfarin. So that is probably one of the limiting factor which we have found in our country. But as some of the drugs will go off patent, the prices will come down, probably will be in a better position to use more NOACs, because the trial data from all the clinical trials, from the RELY, from Aristotle, from the ROCKET-AF, and even now the ENGAGE study, have clearly shown that the newer oral anticoagulant agents are better than warfarin in terms of efficacy and in terms of safety, particularly the reduction of intracranial hemorrhage. So with this data, background data which is where every patient of non-valvular atrial fibrillation should be on newer anticoagulant drugs, because we have learned now the vitamin K antagonists have their problem, because they need monitoring, they have got drug interaction, they have got diet interaction, and so much of variability of the INR, which leads to increased complications while using vitamin K antagonists. So I believe in future probably we'll be in a better position to use the newer drugs, and also even vitamin K antagonists to our patients, those who need it. Unless and until we do this, we are going to have more and more stroke and more cardiovascular events in future.